Good afternoon or good morning, wherever you are. My name is Mohan Tanniru. I am an adjunct faculty in the College of Public Health. My goal today is to talk a little bit about population health and how we re-envision population health in today's environment with focus on leadership and strategy, and of course look at the role of AI in that context. So what is the difference between the direction that I'm going to take today versus traditional thought process in population health and the leadership aspect of it? Traditionally, we look at population health from a clinical perspective, but it's not clinical, it's not even technical. My focus here really is on what is the leadership strategy and how do they re-envision or redesign their approach to addressing population health, more specifically in the way they address the care journey of the population. And of course, the talk today is going to look at what is the role AI can effectively play in supporting that leadership and strategy. We're going to discuss that in three parts. First, I'm going to talk about leadership and strategy and the shift that need to occur to address the care engagement or care strategies to address population. And part two, we're going to look at AI as a potential vehicle to support the leadership. And third, we're going to use some examples to illustrate the approach that I am going to discuss. Leadership. We know for a fact that leadership always is used to set direction, set goals for the organization, and motivate the staff and others to help the organization reach those goals. And in the process, they engage in strategies that allow the organization to operationalize various activities and resources to address the needs of the organization as it addresses the care journey of the population. Now, one of the challenges today is that both the patient environment and the technology are changing rapidly, which means that the leadership cannot be static. It cannot simply assume that whatever strategy that they have designed will work for a reasonable amount of time. So you need to be adaptive as the needs change and as the technology changes. So quickly, leadership can be categorized into three components: regular or administrative leadership that focuses on how to address the normal operations, and innovative or digital leadership or enabling leadership is used to explore new ideas to address the changing needs of the population, and then explore and evaluate whether they are viable. And of course, adaptive leadership is what is used to assess the effectiveness of those that are explored so that they can be incorporated into the regular operations. Now let's shift from what organization does to patient care. Now, patient care itself is changing from a provider-centric approach to a patient-centric approach. What does that mean? We're basically saying we need to prepare the patient within their own ecosystem. For example, if you are trying to address a surgical operation on a patient, you need to prepare the patient within the patient ecosystem. If you want to care for the patient after they are discharged, you need to focus on what kind of transition you need to engage in to support the patient within their own, again, ecosystem. And more importantly, as organizations support patients over a longer time, especially when chronic care patients, you need to address how the strategies address the care transition of the patient from one journey to the other. So these are all focusing on the patient side, and the question then is, how do we shift the leadership strategy to enable the patient to manage their journey within their own ecosystem? Now, as I said, conceptually, you are moving from a provider-centric to a patient-centric. And the moment you do that, you are trying to understand who are the players that I need to engage in to support the patient in their ecosystem. Yes, providers contribute significantly to that journey, but you also need partners, to community partners, clinical or non-clinical, to support the patient journey. And more importantly, you also need to engage the patient, because ultimately, patients need to take ownership to manage their care. So that means you are moving from an organizational leadership to what we consider important here is the inter-organizational leadership. Now, what do we mean by that? Research talks about inter-organizational leadership calls for different type of capabilities. And these include relationship governance, which means organizations or multiple organizations collaborating, they need to make sure everyone goals are aligned to support the goals of that interorganizational partnership, which is to improve the patient outcomes. And of course, because you are dealing with the multiple organizations supporting the patient, you need a digital platform to orchestrate the resources. And the resources tend to be information and any other types of data gathering that is necessary to ensure the patient journey is supported. So there is that digital platform that is necessary to orchestrate resources, but you also need people to contribute to that resource by making sure that their goals are consistent with the goals of the patient you're trying to support. Now, that brings strategic shift, because when organizations are providing leadership, they're focusing on strategy to support the organization manage the entire process within the organization. But the moment you move to the inter-organizational context, you need to start thinking about not just a strategy within the provider, but really across multiple partners and including patients. So here we define this as 3 different types of strategy. Micro, which is provider-driven. Yes, even patient journey outside the system can be supported by a provider if he or she chooses that. But more often than not, you actually engage in what we refer to as a meso strategy, where you are actually engaging patients and partners to support the patient journey. And macro strategies, where we are looking at the entire ecosystem of patients as well as providers and partners. And we will talk more about macro strategies later. The question, of course, is why do strategies fail? Traditionally, providers do a good job when organizations are dealing with a patient while they are in the hospital. But the moment you move to the patient ecosystem, suddenly you have too many handoffs, too many components that are kind of trying to address the journey. For example, pre-admission. Who is going to manage the patient pre-admission so that they are prepared for the surgery? Who is managing the patient post-discharge? And how do they actually collaborate? And of course, care follow-up after the patient is discharged to ensure they are reaching the outcomes. All of that requires collaboration. And oftentimes, many of these strategies do not focus on that collaboration, mainly because no one clearly is responsible for the entire coordination. Each one is looking at their own goals, and they are trying to address patient while the patient is under their overview or under their control. But the moment patient moves from one part of their care transition or one part of the journey to the other, suddenly you have limited follow-up and limited coordination. And that's one of the reasons why a lot of these strategies outside the organization fail. So what is the hidden problem that we are trying to address? Well, we know that there is a fragmentation, And the fragmentation is because we are trying to address the patient care journey broadly speaking, not addressing a particular condition when a provider or a partner is interacting with it. More importantly, that fragmentation suddenly creates the opportunities for gaps in the care delivery and means it affects the outcome that we are trying to accomplish. So the challenge then is, how do we become much more effective in ensuring that coordination does occur across these multiple partners and patients as well as providers? And since we recognize that there is no single entity responsible for it, so let's kind of look at multiple dimensions where this breakdown could occur. So we're looking at clinical implications of that breakdown, both in terms of complications on the patient as well as readmission challenges hospitals often face. Economically, there is significant inefficiencies because information is shared multiple times and sometimes with inconsistencies, and that creates wasted resource. And more importantly, it also creates problems socially because you are not continuing to monitor the patient's social determinants across multiple partners, because each one is trying to figure out what patient needs, and in the process they may have lost some of the information that one particular provider had and the partner may not have, or the partner had and the provider may not have. So the key, of course, is how do we improve the communication among the external parties so that you can improve their collaboration. So that means we need to address both, as we talked about, aligning the goals. Again, the goals in this case have to be both clinical goals as well as the social goals that patient worries about more often. And of course, you also need to make sure that everyone understands the shared outcomes that we are all working towards. And obviously, you need that data to be communicated, means you need a platform that supports sharing of data, enables coordination, and more importantly, it needs to capture the feedback, because often in coordinating efforts, there are going to be gaps in the way you communicate, and that leads to a breakdown in the collaboration. So you need to be able to ensure that you gather that gap or understand the gap and start figuring out how do we address it. So this brings up to the second part. So we talked about why fragmentation occurs across organizations, why communication is needed, and it's needed because we want to improve collaboration among the parties. The question is, can AI help this fragmentation? That means, can it help address the alignment of goals? And also, can it act as a digital platform to support that sharing of information so that everyone is operating from the same set of assumptions? And let's look at that a little bit. What would AI as a coordination layer might include or might consider? Obviously, it is not going to replace a provider or a partner or, of course, patient. It is intended to connect the actors so that they are all working towards the care continuity of the patient. Secondly, it needs to be measuring the value that it is providing to the parties. Remember, use of AI is no value unless it addresses the fragmentation here. That means it has to reduce the readmissions that hospitals are worried about, improve the quality of care that patient is worried about, as well as equitable access to care, because that's something significant population today suffer from because of their inability to either access the care or follow through on the care. So that means, what should AI do? Well, obviously, we know it has to coordinate because that's one of the key goals. But more importantly, that coordination should include communication and assessing the gaps and understanding how the gaps can be fulfilled by appropriate parties. Efficiency, obviously, it has to address the information that need to be communicated and how effectively it can be communicated so that there is no loss of resource, which is one of the objectives when we talked about loss of resource or wasted resource. And more importantly, it supports the safety net, because ultimately you want to make sure that a patient is not left being in the vacuum, so to speak, because they don't quite know what they need to do it going forward, or they don't know who to reach for. And scaling. Obviously, when you are using an AI to support population health or a particular population, you don't want that system to be a one-off. You want that to be a broader, scalable to support broader set of population with potentially different conditions as need and with different situations that they experience in the process of their care journey. So again, if you think of an example, I come to a hospital for surgery. How do I prepare myself? Who are the people that I need to interact with to address that? If I am discharged, what information I need to have, and who do I follow up with? And yes, some information is provided by the hospital when you are discharged, but where do I turn to if I have questions? How do I follow up on various procedures? And more importantly, where do I seek resources when I have complications or challenges? So there are a lot of questions that patients have as they go through the journey. So you want to make sure that the overall effort in this context for the AI agent that we're looking at, our AI system, to help address some of these complications or some of the challenges patient has in addressing their entire journey. Now, traditionally AI, just like any technology, is used as a tool to address a particular situation or a problem. But we are not talking of a tool. We want to have AI as a system to support the overall coordination effort that we are trying to create or design in supporting the patient. So that means it has to be viewed as a system rather than just as a tool to fix a particular or answer a particular question or perform a particular task that you was asked to provide. Now, I don't want to get into a lot of variations and technical aspects of AI here, but we're focusing on generative AI as opposed to discriminative AI, which is used in predicting and classifying, for example, in medical diagnosis for a hospital, use it for addressing the potential risk of a patient getting readmitted. But that's really looking at historical data and classifying to see what conditions exist. But here we are looking at generative AI, which is really to create a new content. And within that, we are looking at LLMs, which are really using natural language to create content and context as needed. And agents, of course, are the next evolution where you use more specific prompts and others to perform a particular task that you want the agent to do. And now we are looking at the next evolution with agentic systems, where we are asking the system to perform or address a particular goal. So you define the goal to be coordinating a particular patient journey. It needs to be able to define what tasks it needs to do and how does it perform these in order to support the patient. So we're looking at more of a systems approach to address the coordination. Now, let's kind of reframe that AI in this case, not as a simple entity that sits on its own, but becomes a part of the overall patient journey supported by a community model. Well, what do we mean by a community model? Typically, any time you are supporting the patient outside the provider system, we talked about providers working with partners and patients in designing strategies to address the care journey of the patient. Within the patient ecosystem, that means the agentic AI or system that we're thinking of is really to become a part of that community model. Not independent, but it should be an integral part of, it should be a part of the actor that is designed to support that community model, address the needs of the patient journey. Which gets into the second question, what is that journey? Because we don't often think of patient journey in a broader context. We often think of, patient comes to me, I provide a service. But reality is, patient journey is almost like a decision-making process of any individual where, for example, when they have to make a decision to get a treatment or engaging in a preventive activity, they need to understand what is their condition, what are the options available to them, and then have the ability to make the decisions. So those are often referred to as awareness and decision support services that they need in order to help them make the decision. Then, of course, once they make the decision and engage in the journey, then they have to think about, okay, what do I do post the treatment practice or post-preventive practice that was given to me? I got to engage in that activity for a longer period of time. And also, I need to make sure I have the opportunity to share feedback to the providers or partners so that they understand what the gaps are so they can address my challenges. So we classify care delivery services that patient journey needs into awareness, decision support, engagement, and feedback. Now, the question is, the strategy shift that we talked about, the strategies have to address these journeys. Now, the question is, again, can it be a micro strategy when the provider does all these phases of the patient journey, support all the services? And there are some providers, by the way, that use some kind of a digital front door as a portal service to support every aspect of the patient journey. But it doesn't address a lot of the challenges patients have. But more importantly, you need more of a meso strategy where providers and partners decide what part of the patient journey they want to support and what part of the journey others want to support. So that way they are sharing the responsibility of the type of services you are trying to design to support the entire journey. For example, provider may, for surgical assistant, may provide support to help the patient prepare as a part of the early treatment evaluation. But then once the patient is discharged, the partner that you may hire actually be using their strategy to help the patient follow through on the practices. So in a sense, it may be a combination of providers and partners deciding what they're good at so that they can engage in that journey more effectively. And of course, network-driven is the macro strategy, and we'll talk about that later. Now, this comes critical because ultimately you are providing these services, but these services have to eventually empower the patient. Because just because I'm making something available to you or making you aware of something doesn't automatically make the patient become aware, because we are looking at it from a provider perspective. So you need to think in terms of how do I empower the patient with that knowledge they need within their own context. So the research on empowerment talks about 4 characteristics. Meaningful information in a way that patient can evaluate what is it that is being presented. Self-determination, giving them the option so they can decide what option they want to choose. And once they do choose it, capacity building. How do you build the tools and build the resources that allow the patient to feel like they can manage that engagement rather than always relying on external sources? Of course, if they have to rely on external sources, they have the capacity to reach them. Lastly, impact. Ultimately, anyone that is engaging in a journey to reach a goal wants to make sure that they are making progress. Otherwise, they lose incentive. So one of the things we want to do is to make sure we provide smaller amount or incremental metrics that allow the patient to feel like they are actually making progress reaching that. So the agent communication, as it supports these services, has to keep in mind that the information has to be contextual and enable the patient to do some of these things. Now, as I said, the agentic AI capabilities then has to be informing the patient in the right way based on the patient context, guide the decisions, seek information, and if they ask for resources, provide the resources so they can make the decision, support their behavior, especially after they begin to engage in the journey, make sure that they have the capacity and they have the resources to manage it. Lastly, it has to make sure it supports the demonstration of the impact. I remember working with a public health agency, and one of the things is, look, I can ask you to improve your nutrition or physical activity, but if I give you, okay, you need to improve your physical activity by X number of steps every week, so you are giving measures which they can use as a way to see if they're able to do that. So you have to give the metrics, and you got to make sure you are enabling the patient to assess that impact. Now comes the critical part. Does the patient trust the system? Because trust is the foundation for any individual entity to feel like they are actually willing to accept the recommendations made or the recommendations provided by a particular entity they are interacting with. It's a problem with providers and patients sometimes. Sometimes providers may say something that patients don't trust, especially if the patients don't have the cultural and economic and other background that to understand fully what the physician is saying. So the question is, how do we build that trust? Well, the characteristics that we talk about in responsible AI is transparency. Make the system communicate that what its role is in the overall strategy of the community model. Make it clear what its accountability, what is it is responsible for, and how is it making sure it's meeting their goals. And privacy, of course, we know that is a critical issue in dealing with information. And the human oversight, and that is anytime you're using a system, in this case AI, there is always going to be a challenge as to what if I want additional clarification? What if I want to talk to someone? Does it have the ability to provide the human in the loop in a way to make sure that it is building that trust with the patient? So we want to make sure that these trust characteristics are embedded in the way the information is presented to address different services that we are trying to provide to the patient. Now the next question, the social context. Even with all the trust embedded, even if all the meaningful information, not all the patients are alike. Each one has different social, economic, cultural background. Their education is different, their income levels, their family level of support. So there are many characteristics that have a bearing on how patients react to the information that is presented. And so the question is, can one bring in that trust, the social component, in the way the information is shared with the patient? And again, there are issues like reliability. Make sure the information is reliable in a way that patient can understand it. And responsiveness. If they have challenges, if they have questions, you want to make sure you provide that information to ensure that they feel that they're responded to. For example, when I was working with an indigenous population, and as a part of my research, one of the issues, what if they feel like the information you presented is not accepted by the community? Can you respond to that issue? Can you come up with alternatives? Can you find sources they can refer to so that they can actually gain better understanding of what you're recommending? So to some and of course empathy, because people of different cultural background may have different abilities to interpret and analyze and make decisions on their own to engage in that activity. So the question is, if they have challenges, can the system become aware of it and become more empathetic in the way it communicates? And of course, lastly, having some kind of a feedback mechanism that allows it to first know aware that there is a problem and try to address the problem. So the question then is, if we are to use, broadly speaking, an agentic system with a specific goal to address the breakdowns in collaboration and coordination between different parties we are talking about, it needs to at least have some of these characteristics. It needs to address the needs of the patient in terms of services. It needs to be empathetic based on the social context. It needs to empower the patient so they feel confident they can engage in the activities that you're asking them to do. And of course, it needs to build trust by communicating its role in the overall ecosystem that it is trying to support. Okay, that's all great. Let's ask ourselves, how do we actually operationalize this? But before I do that, let's think about, or at least reflect on, what happens if AI is implemented in a fragmented system. Disconnected patient journeys. Well, we all know technology that is not actually designed properly can lead to more problems. Way back when we are dealing with process redesign, we said obliterate the process or redesign the entire process before you use technology, because a disconnected, improper, error-prone process using technology is not going to help. So you have to almost redesign your entire role that you and providers and partners play in supporting journey, and then decide what role then AI is going to play. Okay, so let's take a couple of examples. And this is where my part 3 ends, towards the end of our presentation. But I'll illustrate some things that could potentially be leveraged as we discussed. There are 4 different patient journeys here we talk about: pre-surgery, care transition, post-discharge, maybe a wellness that patient is asked to do to engage in having a healthy behavior using nutritious food and physical activity. And of course, if they are stressed, maybe they are recommended to go to a therapist for rehabilitation. So there are 4 possible journeys a patient may engage in. And here I just listed, assume that there is an agentic AI system supporting each of those journeys individually. So let's look at first agentic AI system, for example, supporting pre-surgery assistant. So what do we want that assistant to do? Again, let's go back to the characteristics. What is the service we want to provide to the patient at that time? Well, obviously, they are making early decisions on, do I want to go through surgery and how do I prepare myself? So you need awareness service. That means the patient needs to know what they should be aware of and what type of options they have if they are asked to reduce smoking, if they are asked to reduce weight. So what are some of the things they need to do to change their behavior to support that? And so it's let's say we call it a micro strategy. Of course, it could be a meso if the provider delegates the responsibility to somebody else. And let's look at this care transition. We are using it as a meso strategy because most of the time care transition occurs using a number of external partners like community health workers or primary care providers and others. So there the focus is engagement and feedback because they already made the decision and they already engaged in whatever treatment you provided. Now they have to engage in. So there are 2 different services that each one is trying to focus on. So once you define the focus of your journey, then what is the goal of, say, pre-surgery assistant? What do they want? You want to empower that patient that is looking for meaningful information. And remember, their goal is to be aware and they want to make decisions on their own to make sure they can engage in the behavior you're asking them to do. So that means you got to provide that information in a meaningful manner so they understand what they need to do. Again, different people have a different understanding of what a surgeon is asking them to do. Many of them say you have to quit smoking. Well, what does that mean? Do I quit smoking permanently? Do I reduce smoking? What does it mean for me to actually engage in that behavior? And how do I do that in a short time? Are there strategies you recommend? So there are things that you want to communicate that allow them to feel like they have relevant information and they have options to select from. And of course, support consultation as needed and reminders. And this is a busy slide, but basically, if you are going to use a responsible AI in support of that, obviously, it needs to communicate and say, hey, I am an AI agent supporting a surgical staff. My role is to help you understand what you need to do, provide you reminders, give you options. So make your responsibility, or system makes its responsibility clear. And of course, it says, look, yeah, I can provide you connections to the staff if you feel you need to talk to somebody. But these are things that were provided as guidelines for you to follow based on your surgical process. And of course, make sure you communicate that all the data is HIPAA compliant and it is maintained confidentially speaking. And of course, ensure that the data is representing the particular type of patient that's seeking help. You're not just giving general guidelines, but I'm provided only the guidelines for you based on your characteristics and your situation or your particular condition that you're asked to address. Now that comes to the social context. Social diagnosis says there are two types of situations that are critical during the pre-decision-making process. How does the patient react to their condition, to the potential for a surgery in this case, and what kind of role they play in their own environment to feel like they have the capacity to actually engage in the preparation needed for the surgery. Say, for example, if they're employed, do they have the time to do some of the things? Or if they have taking responsibility within a family, do they have the ability to address some of the changes you're asking them to make? And if they're stressed out because they're going through a surgery that is maybe complicated, where can they address? How can they address that stressful reaction to the surgical process? So role and reaction that are critical to address during the pre-decision-making process of the patient. So that means the agent needs to understand and be able to be designed in a way to be responsive to their challenges, as well as make sure it provides reliable resources that patient can use to follow through on some of the preparation. So you have to be contextually relevant to the context of the patient during that situation. Again, you can think of who prepares a patient before surgery. I remember the case where a surgeon said, many times we give instructions, they come to the surgical room, we find out they are not at all prepared, and we end up either canceling the surgery or basically telling them, after all the money they spent to come here, that they have to reschedule at a different time. So the challenge really is, think about all the things one could do ahead of time and what type of coordination could an AI agent or a system that we're thinking of help address some of those barriers or preparations. And quickly, this is a repetition but in a different context, care transition. Again, care transition is more about empowering patients on the engagement side, and that is give them the capacity to manage whatever you're asking them to do, like manage symptoms, follow up on care, and education that is needed. So recognizing what is the context, make sure you're able to provide the appropriate support. And of course, measure that they are actually doing those things to assess the impact. Again, going back to responsibility, similar context, communicate its role, demonstrate its accountability for the action it's making, and of course, keeping human in the loop. Okay, so we just talked about care transition assistant addressing engagement and feedback part of the patient journey. And we looked at the responsible AI characteristics it needs to support, and of course, also the empowerment services. We also need to look at the social context of the patient. The relevant aspect of social context for these two phases of engagement and feedback is what is the level of relationship patient can rely on in order to be able to follow through on the engagement activities, and what kind of resources are available. So these two become critical. So that means the agent needs to recognize that they are on a different phase, and they need to make sure that patients have the right resources available, they have answers to questions related to resources, make sure the information presented or resources presented are available. Because one of the challenges in dealing with underserved populations is you provide them a resource, but they are not sure if those resources are available to them. So the question is, how do you recognize the equity challenges of the patient about their ability to gain access to those resources and empathize with them and say, look, you know you are concerned, but here are the resources that have been already vetted, and they are available for you to engage in that service. So in a sense, you need to recognize that the social dynamic calls for a different type of empowerment that patients need to have in order to feel like the agent is actually recognizing their situation and helping them address both the access to resources, and if they don't have the family relationships, how can I seek additional support from peers or someone else that could empathize with their challenges. So the empathy and assurance become very critical in the engagement phase, whereas the sensitivity, responsiveness, and relatability become critical in the engagement, in the awareness and decision support phase. So again, going back to the same question, who owns the patient after discharge? And many times, no one owns the patient because you assume that patient is responsible for everything. But the reality is, if you are going to support coordination of that patient journey, someone needs to take the ownership on coordinating their care. And that is what we're hoping the role of agentic AI system could do, is become that coordinator and seek the appropriate resources that are necessary to support the patient. So what does it all mean? If we are going to make AI work in supporting the breakdowns we talked about, it has to align the goals of the patient, provider, and the partners. Obviously, that's a part of relationship governance. That's a characteristic. Patient context. It needs to understand that the information it uses to communicate, the recommendations made, or the resources that are made available, and the support services that are designed are contextually relevant to the patient. And more importantly, it is acting as an intermediary of sort, or it is engaging the human in the system. So it's a combination of human and AI working together as a part of the community model actor to support the patient. Now, one last piece here, the environment within which patient lives is continue to evolve, because even if you understand the patient context, their environment continue to evolve means the context may change. And secondly, as we talked about, patient transitions continue to change depending on the condition of the patient. So somehow or other, the adaptive leadership that we initially talked about that addresses the evolving nature of the patient has to be also recognized that whatever assumptions we made about the patient context will change, and how does the system recognize it and inform others to be able to make the appropriate adaptation to their strategies. And here is a quick picture of it. The concept of value-sensitive design is talked about, which basically says patient values and their priorities continue to change as their ecosystem changes or their environment changes. We know for a fact during COVID, patients' priorities changed because they have different values that became relevant in the context of the managing their infection and addressing their food and transportation insecurities. So you need to have the system somehow be available to surveil the environment and identify what factors might influence the patient context and seek information from the patient on are the things that were discussed by the provider in terms of what they need to do, are they still important to them? Did their priorities change if something else came up? So to some degree, it needs to be cognizant the environment could impact the journey that you're trying to support. And the same situation on the partners and providers. Their ecosystem may change as well because their regulations change, or the technology might change, and they have different funding models that may have evolved. So that means the provider-partner goals may also change. So you need to somehow have the agentic AI recognize that if it is to be acting as a coordinator role, it needs to not only act as a coordinator for certain context in a certain time frame, but it needs to continue to adapt as the environment changes, which means it needs information that it can track. And lastly, transition. Patient has to go from one stage to the other. The question is, what is the role of these agents we are designing, agentic systems we are designing? Somehow or other, they need to communicate with the others to share the whatever coordination effort one has put in to the next system that allows them to continue the journey without reinventing the entire information exchange that occurred between the patient and the system. So that's where the macro strategy comes in. Support patient transition across many different journeys. And that means you might need potentially a multi-agent network where each agent has a role to play in not only supporting the patient in their facet or in their area of role that we define in terms of pre-surgery or care transition, but recognize that it may need to transition some information that it may have gathered to other systems that are designed to support their wellness or their behavioral therapy or whatever other aspect that you want the patient to transition to. So that network vision is where you make potentially extend the single agent supporting a single community model to multi-agent, potentially sharing the context and coordinating the care of the patient over a period of time. So, in summary, we are trying to address the breakdown. That is our key problem. And we're saying that requires a leadership shift, it requires a strategy shift, and we also said it may potentially leverage AI to support that coordination role to address the breakdowns. Now, more specifically, leadership shift includes thinking beyond the organization, build relationships with partners, and invest in the platform that is needed to share information, and of course, align incentives for the partners to contribute to that interorganizational community model. And strategic shift means you got to figure out how do I redesign the way I coordinate today to support the new coordination now with an agentic AI system as a partner in that effort. And I need to think of leading the ecosystem within which providers and patients and partners are working within. And also think of using AI strategically. You need to define what is the role it is playing, what is the value it is contributing, and how do you make sure we design it in a way it addresses the multiple layers we discussed, the social context, the empowerment goals, and the responsible AI requirements so that it can be governed. And again, empower patients, address the social context, and act responsibly. So the key insight from the talk is really population health is really a leadership challenge. It's not a clinical, yes, clinically you need to be addressing the quality of the patient. Technologically, yes, you need to leverage technology to support patient continuity of care. But all of this is not going to happen unless there is a leadership shift in addressing the needs of the new ecosystem that you are trying to create. Last thought. What would your organization do to improve coordination? Now, it's not to say as a reflection, just as a, but it is really more organizations struggle with deciding what they want to invest in. And you can have a broad plan like what I laid out, or you may think broadly, but you may still have to figure out what incremental steps I can take towards accomplishing the broader goal. The concept of radical planning and incremental implementation is often talked about in business. And basically, that's what we're trying to say, that if we are going to use strategically AI, redesign your processes and redesign the leadership you need, and define your strategic framework, and decide what role AI is going to play in that, in supporting the journey of the patient. And then maybe you may build these things systematically but incrementally, so they all help you reach the goal. With that, thank you. I appreciate your attention.